all the way from Harvard University.
I know.
So,
Just say that.
so are we waiting for someone or should we start now?
Hi everyone. We aren't waiting for everyone. I think we have all the panelists are here. So we again are live. Let me just start off and welcome everyone. Welcome to all the. I think there is an echo, a problem from my end. Great. So welcome everyone. Hi, and welcome all the attendees and speakers for this discussion and webinar that we have here. This discussion is on the occasion of World Patient Safety Day with the topic challenges and opportunities for implementation of a patient safety program. Now, this webinar has been organized by SF Healthcare and is in collaboration with Voltus Clover and is supported by AHPI. I'll just request Dr. Ashwini to take this over from here. Dr. Ashwini, over to you.
Hello, good afternoon, everyone. This is indeed a pleasure to welcome all the dignitaries and all the esteemed panelists to welcome. There's some echo. I think somebody is logging from sides.
I think, Dr. Ashwini, this echo is from your end because everybody else is mute. So I think.
Now.
It's better. Yes.
Okay. So, in a warm welcome to all the dignitaries and all the esteemed panelists.
Dr. Ashwini, have you been logged in from 2 devices or more than one? Because
it's only on the mobile. It's only on the mobile.
Because there is an echo there. I mean, there might be a case that somebody else from nearby you who has joined.
No, not yet. Now is it okay?
While I speak, it's okay. But then when you start speaking, there is an echo and a disturbance from your end. So
I think there was a phone call when I had called. Now I think there's no echo.
Yeah, please go ahead.
I think I had called the answer. I'm sorry. Yeah. So right now we start, and it's really a pleasure to welcome all on this World Patient Safety Day. We have a panel of dignitaries and array of esteemed panelists today. It's indeed a pleasure to have this very, very important event known as Patient Safety. So when long back we started with World Patient Safety Day, many of our colleagues, even doctors, clinicians, they used to feel that why do we celebrate this Patient Safety Day? Aren't we supposed to take care of patients? So then we had a lot of activities. I think at Nanavati Hospital itself, since last 3 years, we have been doing World Patient Safety activities. We do focus on patient safety events. We do train and make the patients aware of their rights and responsibilities. Mainly the clinicians, the nursing staff, the technical staff, all of them, we make them aware. Why is the patient safety important? Why do we celebrate this day? And way forward, what are the activities which we plan? Because clinical care is one for which patients do come. But yes, it's a service industry. There are things which are connected, which can definitely, slightest error can harm a patient. It could be simple, like all the panelists here are extremely highly professional in their field. They are going to enlighten us. So this importance, like to mention, what is patient safety? If we go, is absence of preventable harm to a patient during the process of healthcare and the reduction of risk of unnecessary harm. This is very important, which is reduction of unnecessary harm associated with healthcare. And it could be to a very much barely minimal acceptable level. It could just range from normal medication or prescription errors till the patient, high-risk patient falling down. So, and this year is an important event because WHO has declared as the safe maternal and newborn care. I think I have worked myself as a pediatrician, and this is really close to my heart. So WHO has urged all stakeholders now for safe and respectful children with the theme safe maternal and newborn care. So with this, we want to continue. I won't take much of your time. We would now like to have our esteemed chief guest for today. I would love to introduce all the speakers individually when the sessions are planned. I'm sure the agenda, everyone is aware, we have got the agenda. So we'll stick to the time. And with this, it is a pleasure to introduce Dr. Girdhar Gyaniji, who is a director of HPI, Association of Healthcare Providers of India. We all call Sir as of quality, is the father of quality. Sir has having 5 decades of experience in administration, research, and quality. He is widely recognized as founder of healthcare of quality in India. During his tenure as Secretary General, Council of Indian Quality Council of India, Sir has played a pivotal role in formulation of NABH, which we all rigorously, diligently follow. We all are excited to have associations accredited by NABH. Sir has also pioneered quality accreditation in various disciplines like public services, school education, environment and food safety, besides in the manufacturing sector. With this, I would now like to request Sir Gyani sir to have the opening session. We declare the session open and we want to have your inaugural address, sir. All over to you, Gyani sir.
Thank you, Dr. Ashwini. And I'm here to greet everyone today on the International Patient Safety Day, which, as you rightly mentioned, was initiated by WHO in year 2019. And most important indicators of health system in any country is MMR and IMR. And WHO this year is focusing on these two very factors. In fact, when I think of patient safety in healthcare, obviously patient safety has to be in the healthcare. I sometimes wonder why actually patient safety is actually essence of any healthcare system. Should be essence. It should have been institutionalized in the systems, in the processes, and there should not have any need to talk of patient safety separately. But as we know, this is not the case, and we keep on, working on improving the patient safety in developing countries, even in the developed countries, for that matter, let me say. Now, let me just compare a few other sectors, like let us say automobile sector, which is highly competitive. It is driven by the consumers. They don't talk quality separately, because if they are not imbibing quality, they cannot sustain in the market, cannot survive in the market. So that's why in automobile sector, the quality today is institutionalized. You can't have automobile product without quality in the market. Let me say other sector which is not competitive. Let us say the space sector. Let us say if I talk of USA, we have NASA. If we talk of India, we have ISRO, our own body. Now, there is no competition. They are the sole agency in their own respective countries. But by the compulsion, by sense of pride, by the political compulsion, by the cost implication, and as I said, sense of pride, the space scientists just do not think of anything other than quality and reliability. So the space sector, the foundation itself is reliability and quality. So when I talk of healthcare, I know that healthcare quality is driven by 2-3 factors. The one of the factor which comes to my mind is the regulation. Government per force regulates quality in the healthcare sector because health outcomes impact well-being of the society. So it is imbibed on the government that they enforce quality, which actually is the patient safety in our case, in the system. But we also know that, government can't be regulating everywhere. And so this is okay. Some base quality you can establish through regulation, but not really the kind of patient safety today we are talking. The other factor which is there in the healthcare is the payers. Luckily, the payers, insurance company, government insurance companies, they are able to drive because they are paying for it. So they can always impose the conditions on the hospitals that you must have this kind of outcomes before we make you the full payment. So that is working to the great extent. But my wish is that healthcare should become like automobile sector, when patient will be driving the healthcare quality and patient safety. I will take a couple of minutes because I am only initiating the webinar today. If I want to really think of the patient safety, my first thought goes to Florence Nightingale. She was the one who could really apply statistics and bring out the fact that how patient safety can be improved by improving the sanitation. That was the fundamental foundation laid by this great lady. That was in the year 1854. Then I will like to mention Dr. Codman, who during 1911 to 1916 brought the concept of end results. And in the healthcare, you may have any system, you may have any processes, but in the end of it, if the end results are not conforming to what we are expecting, what we are looking for, you are not driving quality. So actually, he made the greatest contribution in the area of patient safety. Then I would like to mention the American College of Surgeons. I think hats off to this institute. Right from 1918 to 1950, they were driving inspecting hospitals in USA for the quality based on their own checklist. Actually, they were, of course, inspired by the work of the Codman. And that is where 1951 gave birth to Joint Commission, Canadian accreditation, Joint American accreditation. They really laid the foundation for framework of quality and patient safety. And let me also mention the name of Dr. Donabedian, who in 1966 changed the way how the quality and patient safety should be evaluated. And that was where, 1987 Joint Commission and rest of the world changed how we measured the quality through structure, processes, and outcome. So outcome remains the primary, as the Codman had done. But important was that instead of measuring directly the outcome, we also focused on efficiency, which came through establishing the right structure, right processes. So I think this is briefly the evolution of quality and patient safety. Let me also highlight the Institute of Medicine, the impact of a study done by Institute of Medicine. Why I would like to mention that? Because they did it in 1999, as far as 1999, when, let us say, USA was practicing accreditation from 1951, and they found that 49 to 98,000 medical errors were happening in that country. I think that opened the eyes of the world that this is what actually is happening. And maybe I think that initiated WHO to start the World Patient Safety Day in 2019. In our own country, of course, NABH now is established, and we are, I think I can safely say that today none of our doctor is unaware of NABH or patient safety. And in spite of all some of the adverse factors, that is shortage of the healthcare in some parts of the country, we are continuously focusing on measuring the clinical outcomes. And I will like to thank here Voice of Healthcare and my colleagues here, and Dr. David Bates, I am seeing is going to speak on the subject today. So I think with that, my initial thoughts I have given, and I will look forward to listening to my colleagues who are sitting here and contribute at the end as and when required. Thank you so much, Dr. Ashwini, Dr. Subrajyoti, and our friend Avinash. Thank you very much.
Thank you, sir. It was really nice, very short. I can imagine the efforts, what you might have taken when you started quality, when none of the clinicians were agreeing. And it would have been such a difficult journey. Now everyone knows quality, everyone knows NABH. And because of NABH, JCI, and entire quality system, we are now able to understand patient safety. I'm sure the lot of data what we read with this patient error definitely is going to minimize, and we are going to have a very long way forward. Gyani sir, really thank you. With this, we now, it's a pleasure to invite, and I know what all efforts have been taken to invite sir, and sir has accepted the our last minute invitation to have his inaugural address. Thank you, sir. With this, we now move forward. Yes, you all are eager to hear. We, in fact, are eager to hear Dr. Betts. Sir has a huge profile. If I have to read, it will take 10 minutes only to read sir's profile. But we would like to welcome on board for this esteemed panelist discussion and for this addressing all of us for the patient safety, the Medical Director of Clinical and Quality Analysis Information Systems, Partners Healthcare System, Division of General Internal Medicine, Brigham and Women's Medicine, Professor of Medicine, Harvard Medical School, Professor of Health Policy and Management. So Dr. Betts is going to enlighten us on various aspects of patient safety. Dr. Betts is an internationally renowned expert in patient safety, using information technology to improve care, quality of care, cost effectiveness, which is very important, and outcomes assessment in medical practice. He is a professor of medicine at Harvard Medical School and a professor at Health Policy and Management at the Harvard School of Public Health, where he coordinates a program in clinical effectiveness. We all have a wish to attend Harvard School for various inputs, but today we are lucky that we are going to hear from sir's valuable pearls of wisdom, I would say, in patient safety. He is the immediate past president of ISQA, we all know, International Society for Quality in Excellence in Healthcare, and the editor of the Journal of Patient Safety. Sir serves as the principal investigator of the Health Information Technology CERT. He has been elected to the Institute of Medicine, the American Society for Clinical Investigations, Association of American Physicians, and American College of Medical Informatics. More than 700 peer-reviewed papers sir has, and has a high index of 150, which ranks him among the most 400 most cited biomedical researchers of any type. I won't take much of the time. We are all eager to hear Betts, sir. All yours, Dr. Betts. We would like to please enlighten all of us on World Patient Safety Day, and please enlighten. A lot of clinicians have joined this program. All yours, sir.
Well, thank you, Dr. Ashwini, and thank you, Dr. Gyani, Dr. Bomek. Thanks so much for this invitation to be with you. Can you see my screen?
Yes, sir, we can see, sir.
Great. Okay, so I've been asked to speak with you today about medication-related harm, and it's very exciting to be able to do that with you today on this World Patient Safety Day. I'm going to talk today about medication safety. Medications deliver great benefit, but they're also a leading cause of harm, especially in hospitals, also outside of hospitals, but I'm going to focus mostly on in hospitals today. And there are tools now to greatly improve medication safety, which I'm going to talk about. WHO has focused on this area in the third Global Patient Safety Challenge from WHO, Medication Without Harm. And I've just given you the reference to that here today. This slide just shows the relationships between medication errors, potential adverse drug events, and adverse drug events. So medication errors are common. Most of them, fortunately, result in relatively little harm. Some medication errors, however, do have the potential for harm. Those are called potential adverse drug events. Some of them don't harm patients just by chance. So, for example, a patient's allergic to penicillin, you give them penicillin, nothing happens. That's the case actually most of the time. But some of the time, the patient does suffer harm and has an adverse drug event. Most of the harm caused by drugs is actually not preventable, given what we know today. We did a study some years ago in which we looked at the relative frequency of these things and looked at 10,070 orders. We found 530 medication errors, or 1.4 for every admission. There were 35 potential adverse drug events and 5 preventable adverse drug events. So that suggests that about 1 in 100 medication errors actually results in an adverse drug event, and 7 in 100 have the potential to harm a patient. A study that we did many years ago was the first really big study that focused specifically on medications and patient harm. And we found in 2 big hospitals in the US that there were 6.5 adverse drug events for every 100 admissions. 28% were preventable. There were 3 potential adverse drug events for every preventable ADE. And most of the errors were at the ordering and transcription stages. Now, before this work, much of the work in this area had been done by pharmacists, and they assumed that all the orders were correct. And that is obviously not the case. We also looked at the costs of these events. Adverse drug events are expensive. Even at that time, they cost nearly $2,500 per adverse event and nearly $5,000 per preventable event. The annual costs at our hospital were $5.6 million for all adverse drug events and $2.8 million for the preventable ones. And those figures didn't include the costs of injuries to patients, malpractice costs, or the cost of admissions due to adverse drug events. This is the kind of thing that can be used to justify investing in prevention efforts. We then did an interventional study, and we took patients and admitted them and looked at both medical and surgical units over a 6-month period. And in phase 2, we looked at all the patients admitted to the same units and 2 randomly selected additional units. And the interventions were computerized physician order entry for all units. So all orders were written on the computer. And then a team-based intervention, which included changing the role of pharmacists for half the unit. When you computerize drug ordering, it improves medication safety in a variety of ways. So people are picking doses from menus. They'll only pick doses that are potentially an option. You can decrease transcription. You can require complete orders. You can also give information at the time that it's needed, like information about relevant labs or guidelines, guided dose algorithms. And then maybe most importantly, you can perform all these checks in the background, like checks for drug allergies, drug-drug interactions, drug lab problems, and so on. Now, when we did that study, we looked over a 15-month period. Computer order entry required that all orders be complete. Transcription was minimized. The decision support that we had in place was really very early, and we still saw a 55% decrease in the serious medication error rate and a 17% decrease in the preventable adverse drug event rate. We didn't see any change with the team intervention. If you look at the distribution by stage, 49% of the errors were at the ordering stage, 14% at dispensing, 26% at administration, 11% at transcription. There are other things that can improve medication safety, including barcoding in an electronic medication administration record. Barcoding is used routinely in supermarkets today. You can also use smart pumps. You can use computerized monitoring for adverse drug events, tools to improve medication reconciliation, and having pharmacists contact patients after the hospitalization. If you look at the impact of these interventions by stage, order entry and decision support reduced the rate of ordering errors by 55%. Barcoding in the pharmacy reduced dispensing errors by 67%. Administration errors fell by 51%, and transcription errors were completely eliminated. So you can see, if you computerize this process, it results in improvements at every stage. So if you look at the whole inpatient puzzle, there are lots of different pieces. The very most important is computerizing ordering. But other things are useful too, like barcoding, point of care technology, implementing smart IV pumps. Clearly, you can't do all these things at once. You also need monitoring and spontaneous reporting. It's ideal to call patients after they get home. And most of these things don't communicate today, and the future will be to build linkages and get the patient more engaged in the process. So, to wrap up, we saw major benefit even with a simple intervention. We've layered on many additional improvements, notably renal dosing. That makes a big difference clinically. Your exact choices to do, especially in a place like India, which is very diverse, will depend on your available resources. But in the US now, it's hard to imagine paper prescribing. And India is very developed in many ways, and I think it will be hard to imagine paper prescribing soon in India as well. So I'd suggest that a potential future for India would be to computerize prescribing, probably first inside the hospital, but later outside it, working towards barcoding of medications, taking advantage of the skills of pharmacists, and enabling prescriptions to be sent electronically. And all of that will result in improved medication safety for India. And I will stop there.
We would like to take the questions towards the end. If I can see in the chat box, just give me 1 minute. Yeah. So can I ask questions on behalf of few clinical inputs, what we have got?
Sure.
Yeah. So many a times we all know that, prescription and then transcription are this points wherein we can definitely catch up and we can prevent. So do you feel this training is required when we are all doing medicine or we are doing MBBS, at our place? And when we are doing the undergraduate course, at that time, we should have this chapter which will inculcate within us, the way we should have the various parameters of patient safety and how we can avoid. I think this aspect of patient safety we learn when we become clinicians and we are already into our practice. So do you have any suggestions on this?
Well, I think the role of pharmacists is going to continue to be important. It's very, very helpful to have a second check in the system. And pharmacists catch, of course, many important medication errors. But if you set up a process so that there are few errors to begin with, then there's less work to do. Today there's so many things that are problems, and the workload of pharmacists is so great. It's very hard for a pharmacist to really check everything and catch all the things that might come through as a problem.
Okay, that's true. So since we have a lot of faculty here who in our country represent the teachers, they are the postgraduate teachers, as the reason this question was asked. And so for the young generation, any specific takeaway message for our young generation here who have recently passed out or who are yet to start their career, any specific instructions? How can we prevent this?
Yeah, well, I would say, what I was trying to do was really describe what the future will look like for India. And as people, get into positions of responsibility in their organizations, this is the sort of thing that they should be aspiring to. It will take some time to implement that, and I'm aware the levels of development are very, very variable in India. In the best hospitals, many of the things that I talked about already exist, and then in the hospitals in the countryside, none of them exist. But I think it's useful to have a sense of what direction you want to go in.
Okay. Dr. Subrajyoti, I feel even you could ask because sir is going to log out of this session since there's a time lapse. Do you want to? Yeah, so that's
Absolutely, Dr. Ashwini, and let me thank Professor David Bates for taking out time from his busy schedule. And Professor Bates, your future for India is really, really very interesting. And I personally had a thought, and I wanted to ask you about, the prescription audits. How important are these audits, and what should be the frequency? Sometimes leadership is not very open to the audit reports, and it's how do we fit in audits in the safety culture? If you could guide us on that.
Sure, I think audits are very valuable. As I described, they often pick up specific errors, but they can also give you a sense of kind of what are your levels of systemic problems. And so routinely examining how you're doing with audits can give you a sense of what your problems are and what things should be focused on. Certain things have emerged from doing that sort of thing in the US. So for example, there were a number of deaths that were related to concentrated potassium. And it turns out that, except in very limited circumstances, you don't really need concentrated potassium. And the most effective solution there actually was to remove concentrated potassium essentially from the whole hospital, except for the one or two places where you really needed it. And that resulted in prevention of many deaths. So there's some examples like that came out of audits and looking at reports of accidents.
Sure. Thank you very much.
Since we have the benefit of time, would any other panelists would want to ask a very, very valuable input question to Dr. David Bates?
Yes, sir. My name is Rajiv, and I would just like to check with you with this electronic medical records that you mentioned and CPOE aspect. Are you using different alert systems to clinicians when they are prescribing certain medications? And is it creating problem or is it helping them?
Good question, and I didn't talk very much about that. Right now, actually, it's creating more problems than benefits. We're getting many alerts. Most of them aren't really very useful. We're working with a company right now, actually, that has software that can turn off about 93% of those alerts, and then we'll be testing that. And I'm hopeful that by making some changes in how we alert and which things we alert about, we'll get to a better place around this. But you're absolutely right that where things are right now is that people are getting many alerts. Most of them aren't very helpful, and as a result, they're ignoring many of the warnings. So the warnings are not necessarily going to deliver benefit if you don't do things right. I suspect Dr. Johnson's had a similar experience at Johns Hopkins.
So we had one question from the RS August audience here: how to improve the culture of reporting for ADEs, adverse events? How do we improve the culture?
So working on culture is important. I mean, I think that what you need to do is take the reports seriously, look at them, and then give the frontline people who are doing the reporting feedback about what was done based on the reports that they made. I do think that the future in this area is actually to use the computer to find the problems, and that will give us a much more accurate sense of how many adverse drug events are occurring. We're currently doing a couple of studies around that, and getting people to report is hard. People are busy. It's still very good for near misses and for errors, but for the actual harm, the best way to do it will be to use the computer to find patients who are harmed, and you'll be able to get a much more accurate estimate of how frequently that's going on. with that approach.
So thank you. I think a huge round of applause for our chief guest, Dr. David Bates. We really acknowledge, sir. Thank you for taking out the valuable time with this time lag. Still, we were we had great inputs from you, sir. Thank you, and look forward to have many more sessions with you and a lot of guidance activities to our academic students. Sir, we would like to have a lot of interactive sessions again in future. Thank you, David Bates, sir. Thank you.
Thank you.
Thank you, sir. So with this, we now move to our next session, which is a keynote address by Dr. Julia Johnson. Again, we are blessed today to have panelists and esteemed guests from all over the world. It's not our city event, it's not an event of a country, but this is a pan-world level what activities, what discussions, what we are doing. It is pleasure to invite Dr. Johnson, who is an assistant professor of pediatrics in international health at Johns Hopkins University in Baltimore, United States. We all know she has graduated from the College of William and Mary with majors in biology and international relations. Dr. Johnson is an Alpha Omega Alpha graduate of Eastern Virginia Medical School. She completed a pediatric residency and a fellowship in neonatal perinatal medicine at Johns Hopkins University. Dr. Johnson joined the faculty in the Division of Neonatology at Johns Hopkins in 2017. Her research interests include neonatal global health and infection prevention. Dr. Johnson has conducted CDC-supported research in Pune, India, describing the epidemiology of bloodstream infections in the NICU. It's interesting to hear that it's from Pune. Identifying reservoirs of transmission for resistant gram-negative bacteria and for neonatal infections, how can we prevent them? Plus performing an intervention study to improve healthcare worker adherence to evidence-based infection, prevention and control practices. She has completed a PhD in clinical investigations at the Johns Hopkins Bloomberg School of Public Health in 2020. Her thesis, Healthcare-Associated Bloodstream Infections in the Neonatal Intensive Care Unit in Pune, India. Epidemiology and reduction of risk, focused on quality improvement and patient safety interventions in 4 Indian NICUs. She was awarded a K23 Mentored Career Development Award by the National Institute of Health in July 2020, which will support her continued work on epidemiology of healthcare-associated bloodstream infections and infection prevention and control in the NICU in low-resource settings. Dr. Johnson has recently established a new partnership with the Maternal and Child Health Center India, Peerless Hospital, and Chittaranjan Seva Southern College of Obstetrics, Gynecology and Child Health in Kolkata, India, with an upcoming prospective cohort study to describe the epidemiology of neonatal sepsis. Indeed, this is so we just get connected with such a nice profile with a lot of neonatal work going on, and it requires, this coincides with this WHO World Patient Safety Initiative, wherein we are committed to improve the neonatal care, as these are the healthy assets, intangible assets of the future. So with all this, we are eager to hear now to Dr. Julia Johnson. All yours, ma'am.
Thank you and good evening. Give me just 1 second while I pull up my slides. Can you see my screen? Great. All right. Thank you to the organizers for inviting me to speak on the occasion of World Patient Safety Day. I'm thrilled that the focus of this year's World Patient Safety Day is safe maternal and newborn care. As a neonatologist, I'm passionate about improving maternal and neonatal outcomes, both in my NICU at home and globally. As an infection prevention researcher, patient safety is at the forefront of what I do on a daily basis, including with partners in India, some of whom are in the audience today. Some of the research I'll briefly mention today was supported by the United States Centers for Disease Control and Prevention, and I received current support from the NIH. I have no other relevant conflicts of interest. Objectives of my talk include a brief review of the WHO Global Patient Safety Action Plan with a focus on maternal and newborn health, to introduce patient safety culture as a key safety paradigm in maternal and neonatal care, and to describe human factors engineering approaches to improve patient safety and potential applications in maternal and newborn care. Let's begin with a reminder of why patient safety matters in maternal and newborn care. Every day, there are an estimated 5,400 stillbirths, 810 maternal deaths, and 6,700 neonatal deaths. We know that safe maternal and newborn care can prevent most of these deaths, but global action is needed to prevent and reduce avoidable harm. Some of the key aspects of safe care are highlighted in this campaign poster for World Patient Safety Day. Safety in medications, surgery, blood transfusion, medical devices, radiation, sanitation, and my focus, infection prevention. In its key message to healthcare leaders on the occasion of World Patient Safety Day, the WHO emphasized the need to invest in healthcare workers' safety, well-being, capacity, and supportive supervision, as well as promotion of an environment for childbirth that involves women in shared decision-making, the importance that all births are attended by skilled birth personnel, and the need for adequate infrastructure. It also highlighted the importance of establishing a safe culture in which healthcare workers are not afraid to speak up about safety concerns as a basis for systems improvement. By the end of this talk, I hope that you will see the utility of a safe culture in improving outcomes in maternal and newborn care, including in infection prevention. This figure is featured in the WHO Global Patient Safety Action Plan, which was recently published to guide global improvements in patient safety. The vision, a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere, is supported by key stakeholders, including the WHO, governments, and healthcare facilities. And it rests upon the pillars of patients and families as partners, use of data and scientific expertise to turn evidence into policies and action. And again, we see this familiar term, safety culture. The WHO Global Patient Safety Action Plan lays out how its strategic priorities align with the Sustainable Development Goals. On this slide, maternal and newborn care targets are highlighted. These include, by 2030, the reduction of global maternal mortality ratio to less than 70 per 100,000 live births, and the end of preventable deaths of newborns and children under age 5. Among the examples of avoidable harm are misdiagnosis of high-risk pregnancy, unsafe management of obstetrical complications, complications due to unsafe preterm and intrapartum care, medication errors, and my area of interest, newborn sepsis. I've personally chosen to focus on neonatal sepsis for my career due to its major contribution to neonatal mortality worldwide. Sepsis accounts for approximately 15% of neonatal deaths worldwide annually, but it's worth noting that in countries with the highest neonatal mortality, sepsis and other infections cause a significantly larger proportion of neonatal deaths. The figure on the right illustrates this trend. In countries with the lowest neonatal mortality, the rightmost bar, neonatal sepsis and pneumonia in dark green account for a much lower proportion of deaths than in countries with the highest neonatal mortality, which is the bar on the left. While complications of preterm birth account for the highest proportion of neonatal deaths during the first week of life, sepsis is the most common cause of neonatal death after the first week, accounting for 37% of neonatal deaths in the late neonatal period. These data must be considered in the context of a global increase in facility-based births. This figure features data from demographic and health surveys completed from 4 countries to illustrate this trend, including in India, where facility-based births increased from 39% to 79% over a 10-year period. With this increase in facility-based births, healthcare facilities are increasingly providing complex care to mothers and newborns, which increases risk of harm. Care for neonates who are preterm and sick increasingly occurs in neonatal intensive care units or NICUs and special care nurseries. And the provision of care ranges from basic thermoregulatory and nutritional support to management of infections and respiratory support. One of the harms of increasing importance among hospitalized newborns is healthcare-associated infection. Newborns are among the most vulnerable hospitalized patients due to increased inherent risk with an immature immune system and impaired skin integrity. Especially preterm neonates may require prolonged length of stay and invasive procedures to support their survival. These risks are often augmented by gaps in infection prevention and control. Neonatal infections are especially difficult to treat in settings of high antimicrobial resistance, where associated morbidity and mortality are high and there are limited treatment options for neonates. This map illustrates the global data on carbapenem resistance in Klebsiella pneumoniae, a significant contributor to neonatal sepsis deaths worldwide and one of the most common causes of neonatal infections in India, highlighting the challenge of treating these infections. So let's return to the concept of safety culture. I like this description from the Advisory Committee on the Safety of Nuclear Installations. The safety culture of an organization is the product of individual and group values, attitudes, perceptions, competencies, and patterns of behavior that determine the commitment to and the style and proficiency of an organization's health and safety management. Organizations with a positive safety culture are characterized by communications founded on mutual trust, by shared perceptions of the importance of safety, and by confidence in the efficacy of preventive measures. Derived from this concept of organizational safety culture, patient safety culture is now a core concept of healthcare delivery, as illustrated in the WHO Global Patient Safety Action Plan. In the United States, the landmark 1999 Institute of Medicine report, which was mentioned during one of our earlier talks, To Err as Human, Building a Safer Health System, brought this concept to the forefront of healthcare, and safety culture has been included in a number of WHO initiatives, including its multimodal infection prevention and control improvement strategy. Similarly, the Institute for Healthcare Improvement, or IHI, includes safety culture in its framework for safe, reliable, and effective care, with culture encompassing psychological safety, accountability, teamwork and communication, and negotiation. These elements of culture work hand in hand with the learning system, which incorporates core concepts of transparency, reliability, improvement and measurement, and continuous learning. This figure illustrates the safe and reliable culture maturity model. An immature model is unmindful, where members of the team do not care about the safety of the system as long as they are not caught. The next step is a reactive system in which safety is valued, but action primarily occurs in response to adverse events. A systematic model appropriately manages all hazards. A proactive system attempts to anticipate and prevent safety hazards before they occur. A mature, safe, and reliable system, however, is generative, meaning that safety is how we do things around here. It is a part of the fabric that makes up our institution. This ultimately is how we define patient safety culture. So how can safety culture be incorporated in infection prevention and control? The WHO incorporates safety culture in its multimodal infection prevention and control improvement strategy, which also features system change, training and education, monitoring and feedback, and reminders and communication. Within newborn care, especially the NICU, infection prevention and control interventions often focus on the implementation of a bundle. For example, for the prevention of central line-associated bloodstream infections, ventilator-associated pneumonia, and other patient safety threats. But specific interventions that put patient safety culture at the forefront are more rare. One such example is the Comprehensive Unit-Based Safety Program, or CUSP, which was first developed by Peter Pronovost, a patient safety specialist at Johns Hopkins at the time, who implemented a statewide initiative to reduce CLABSI in the adult ICU. CUSP involves creation of a multidisciplinary team that is unit-based and led by a nurse and physician champion to reduce patient safety threats. The CUSP toolkit, which is available publicly on the HRQ website, incorporates education of staff on the science of safety, engagement of staff in identifying defects, partnership of the unit with a senior executive, identification and learning from defects, and implementation of teamwork tools. It is important to note that while I'm focusing on infection prevention and control, because that's my area of expertise, CUSP can be applied to any patient safety threat, including patient falls and postpartum hemorrhage, for example. So building on prior work to describe epidemiology of neonatal sepsis in the NICU in Pune, we collaborated with 4 tertiary care centers in Pune with NICUs to implement CUSP to improve patient safety culture and adherence to infection prevention and control practices. We focused on 3 areas that are foundational in infection prevention and control: hand hygiene, aseptic technique for invasive procedures, and infection prevention and control practices around medication and IV fluid preparation and administration. After baseline assessments of infection prevention and control practices and patient safety culture using validated assessment tools, sites were provided training in CUS methodology and formed multidisciplinary teams led by nurse and physician champions from the unit. These teams met monthly and using CUS tools, selected and implemented interventions in each of the 3 focus areas. Hand hygiene compliance monitoring was performed throughout the study with regular feedback of data to the CUS team and unit staff. Each site used a 2-question staff safety assessment adapted to each focus area to elicit staff feedback on perceived threats to patient safety. For example, for hand hygiene, each staff member was asked about the challenges in achieving the highest standard of hand hygiene practices in the NICU and how these challenges could be overcome. Responses to safety assessments, which were anonymous, helped inform CUS team selection of interventions for each focus area. Each site ultimately implemented several strategies for each focus area, tailored to its specific needs to optimize infection prevention and control practices. The interventions are here summarized by element of the WHO multimodal infection prevention and control improvement strategy, which again are system change, training and education, monitoring and feedback, reminders and communication, and culture of safety. This slide summarizes general interventions that were undertaken by the CUS team, which included linkage of a senior executive with the unit, sharing of monthly healthcare-associated bloodstream infection data at CUS meetings, use of WhatsApp groups to disseminate information, and creation of a CUS mission statement focused on patient safety. For hand hygiene, key initiatives included change of hand hygiene product to improve compliance, involvement of mothers in hand hygiene education, and compliance monitoring with regular feedback of data. For Aseptic Technique, interventions included implementation of a central line insertion checklist with regular sharing of completion data at monthly meetings and empowering nurses to stop aseptic procedures if appropriate steps were not followed. For medication and IV fluid preparation and administration, the creation of a dedicated space outside of the immediate patient care area to prepare all injections, the completion of an injection safety audit, and the use of bedside reminder flags for central line maintenance practices, such as scrubbing the hub, were selected. Ultimately, CUSP implementation successfully improved hand hygiene compliance at all sites, from approximately 50% at baseline to 73% at study conclusion, which was at 16 months following the intervention. Central line insertion checklist implementation was also successful, with approximately 75% of central line checklists present in the charts of neonates with central line in place at the time of monthly audit. We also repeated the assessment of patient safety culture at the conclusion of the study and noted the greatest improvements in the patient safety domains of management support, teamwork within units, organizational learning, and supervisor expectations and actions promoting patient safety. Key features of CUS included engagement of key local stakeholders with selection of locally appropriate interventions, nurse leadership and implementation of these interventions with senior executive and physician support, as well as the underlying focus on patient safety culture. Beyond our work in the NICU, CUSP has been successfully implemented in several initiatives to improve perinatal care and reduce both maternal and newborn harm. Healthcare facilities have used a CUSP-based approach to create mechanisms for safe oxytocin administration, electronic fetal monitoring, rapid response systems for obstetric care, magnesium administration, recognition and management of obstetric hemorrhage, and management of shoulder dystocia. It's important to recognize that patient safety culture cannot operate in a vacuum, and integration with other key aspects of safe care is essential to reduce risk of harm in maternal and newborn care. Safe maternal and newborn care must include improved access to safe and equitable care during the antepartum, intrapartum, and postpartum periods, with better management of obstetric and neonatal complications, reduction of medication errors and device-associated complications, and decreased incidence of healthcare-associated infections. So returning to our earlier figure from the WHO's Global Patient Safety Action Plan, we must recognize that safety culture is only one of the pillars of patient safety, all of which rest on a foundation of policies to eliminate avoidable harm, high reliability systems, patient and family engagement, healthcare worker education, skills and safety information, research, and risk management, as well as synergy, partnership, and solidarity. An approach that has been successfully used to achieve safer patient care is human factors engineering, which focuses on the design of the system to make it easy for healthcare workers to do the right thing and minimize risk of system failure. Human factors engineering approaches include cognitive ergonomics, which assesses how well the system matches the cognitive abilities of the user, physical ergonomics, or the physical design of the workspace and how it affects risk of error, macroergonomics, or work system design, and usability assessment. Human factors approaches, like quality improvement, are typically iterative, including cycles of evaluation, design, and testing to create the best possible system. Human factors principles to guide reduction of error in healthcare include some of the following: simplification, standardization, avoidance of reliance on memory, improving access to information, and taking advantage of habits and patterns, as well as eliminating environmental factors that degrade performance and creating systems that are better able to tolerate the occurrence of error. In thinking about how we can provide high quality maternal and newborn care, these principles should guide our design to a safer work system. Human factors engineering approaches for safer maternal and newborn care must involve human-centered design that focus on the patient, in this case, the mother and the newborn, as well as caregivers and healthcare providers, with the end goal of safer obstetric and neonatal care by recognition of the complex work system. One framework that has been successfully used in human factors approaches is the Systems Engineering for Patient Safety, or SEEPS model, which focuses on the person at the center of the work system and acknowledges complex interactions among work system elements. This figure summarizes SEEPS 3.0 and these complex interactions between the patient, the work system, and outcomes. The work system includes members of the diagnostic team, tasks, technologies, and tools, as well as the physical environment and the organization itself, whereas outcomes include both patient-focused and system-focused outcomes. Examples of outcomes and interest in SEEPS 3.0 are described here. For example, patient safety outcomes include diagnostic safety, medication safety, already addressed by Dr. Bates earlier, and healthcare-associated infections, whereas outcomes of importance for clinicians and healthcare organizations include the quality of working life, occupational health and safety, and organizational performance, among others. The SEEPS model has been successfully implemented as a framework to address hand hygiene, medication errors, healthcare-associated infections, and a number of other patient safety issues, including nosocomial COVID-19 transmission during this pandemic. And it lends itself well to application to a number of maternal and newborn care outcomes of interest. An example of a recent application of human factors principles included a 2019 Brazilian study where investigators performed a risk assessment of a newly developed incubator, performing a heuristic evaluation of the user interface and usability testing to provide feedback to the developer of the device. So now that we've spent some time reviewing the importance of patient safety culture and maternal and newborn care and the potential applications of human factors engineering principles, let's return to our primary mission. We must consider this year's World Patient Safety Day as a call to action, a recognition that maternal and neonatal deaths are largely preventable through the provision of safe care. Safe care is a global priority that requires local action, and we must consider patient safety culture as the foundation for creating a safer healthcare system for mothers and newborns. I would like to thank the organizers of this World Patient Safety Day for the opportunity to speak, as well as my research collaborators in India and the United States. And there's just a couple of pictures from my visits to Pune.
Thank you, ma'am. It was indeed very enlightening. And it's nice to see that in a lot of neonatal care in the pediatric, and especially we got connected because a lot of studies are in Pune. So this was really helpful for us. And with this, patient safety definitely plays a very, very important role. I would like to take this opportunity if any of our panelists wants to ask Dr. Julia any question. So before they take a break.
Dr. Julia, I had a question. This is Shubhro this side. Yeah. So, Dr. Julia, what has been, I would say the good things you noticed while you worked in India? If people say that it's a developing country, there are many things which are not in proper shape, but we also take care of so many patients every day, and we are managing quite a lot of patients well. So what are your thoughts on what's going right in this country? We know lots of things are wrong, but then your take on that.
Yeah, no, that's an excellent question. So I first started coming to India about 5 years ago, and I have spent a fair bit of time, unfortunately not able to travel recently due to the pandemic, but I have found that the providers of clinical care, especially in neonatology, are incredibly passionate about improving outcomes for their patients. The very first trip I took about 5 years ago was before we had this CDC funding, before we had any particular project in mind, but it was really kind of a discovery trip to see what clinicians on the ground cared about. And it was so obvious that the neonatologists and pediatricians who worked in the unit, as well as the nurses, were so incredibly frustrated by the lives lost and the morbidity caused by neonatal sepsis in particular, how frustrating it was to not be able to save those lives, and how passionate they were about that. And so without initially having, the mandate from a federal organization in the United States to do this research, really that's what the clinicians cared about. I've spent a lot of time talking to the bedside nursing staff and have been incredibly impressed how caring they are and how passionate and how willing they were to dive headfirst into this very complicated interventional study that put a lot of the responsibilities on the nursing staff, and really watching them grow over the course of that intervention, feeling comfortable speaking up in front of senior doctors and really owning the fact that patient safety is something that we're all responsible for, not just the senior most physician who, signs the medication orders and the chart. In terms of just general neonatal care, some of the things that have really impressed me is the real engagement of mothers in the provision of care. And my experience in Pune has been that mothers are effectively often remain in the hospital to provide care until their neonate is discharged home, regardless of how long that is. And that the healthcare facility really supports those mothers in making sure that they are taken care of during that stay. The other thing that's related to that is the incredible ability to provide breast milk for all neonates in need. And so the use of breast milk in the NICU in Pune far exceeds the rates of breast milk use in my own NICU at Johns Hopkins, and a couple of the hospitals that I work with have their own donor milk programs. And one of the pictures actually on this very slide, the top right, is a picture of the breast milk collection van that was used to do observed collection in the community. And so this level of innovation that really is responsible for improving neonatal care, because we know that providing breast milk saves lives and prevents adverse outcomes such as necrotizing enterocolitis. And so some of the aspects over the course of the study that I learned also is just how innovative individuals are, even in the face of limited resources at times. And some of these strategies to improve hand hygiene were incredibly innovative. And I'd already mentioned, like, involving mothers in education of hand hygiene was instrumental. And those are some of the tools I took back to my own unit, because infection prevention is not something that just India struggles with. We actually are currently dealing with a rise of central line associated bloodstream infections in my own unit during the COVID-19 pandemic. And so some of the innovative strategies that were adopted by the NICUs in Pune, I actually brought back to my own NICU at Hopkins and said, that's how we did it in Pune, like maybe it'll work here too. And so innovation is not unique to the United States. And I've actually been so impressed with how invested everyone is in improving neonatal outcomes.
Thank you so much. I think that is really heartening to hear it from somebody who's been on the ground and done real work with the Indian clinicians, the Indian nurses. Thanks so much, Julia. And we really look forward to more collaboration of yours and your institution with this country. Thank you.
Thank you.
Yeah, I agree. Dr. Subrata asked a very valid question. And we are happy that our mothers who take care in the Nicu are being acknowledged. They're the real pillars. Yeah, that's a difference. Because we have seen the mother may have a lot of pain, but still she's there for her neonate. She's there even on a third day, fourth day, she's there with the child, and that helps a lot. Then that's the key factor which differentiates. Thanks, ma'am, for appreciating this. And we really thank Dr. Julia Johnson for enlightening us. This was such a marvelous topic and really an eye-opener in many areas. We thank for your valuable time. We thank for your all guidance to us. With this, we now move to our very own Indian panelist here. It's a really honor to introduce Dr. Subrajita Bhomik. We have hosted many programs, and it was always learning, a lot of learning factors from his part, from our areas, whatever we are doing. With this, we are on a very, very important panel discussion today, which is implementing and driving patient safety in India. And I know it's a very tough task, because now is the age, now people are receptive for NABH, for accreditation, and now to think as patient safety. I remember when first year we took this awareness of patient safety activity, clinicians were a little resistant that what is in this. And when we sat with them, we discussed various topics. It was really helpful from each end. And now Dr. Subrajita Bhomik, I'll be introducing him, and the further panelists will be introduced by Dr. Bhomik, and he will take forward the panel discussion. I welcome formally Dr. Bhomik. It's nice to have you in this session. He is indeed a great CV, but I'll make it very short to have the good panel discussion here. He's a medical graduate from Calcutta University with a gold medal in gynecology and obstetrics. Dr. Bhomik has completed MD in pharmacology from IGMR, what we say, and Calcutta, and was over 14 years of experience in the field of clinical research, pharmacovigilance, and medication management in hospitals. I'm sure with this good background, this patient safety is a very, very important topic for Dr. Bhomik. And we all know the marvelous work what he has done. After his postgraduate diploma in clinical endocrinology and diabetes from the Royal College of Physicians, UK, he has a certification in clinical research administration and project management from Stanford University, USA, and in patient safety from Johns Hopkins University, USA. Dr. Bhomik is an assessor for NABH. He has been assessing various hospitals. He's a qualified NABH assessor for ethics committee and accreditation also. Ethics committee here is a very, very important element for all our clinical research activities, what we carry forward. He has been has done a fellowship in ISQA, in the healthcare quality from ISQA. He was the first doctor to be awarded the prestigious Lucian Patient Safety Fellowship by ISQA for 2019. He has been conferred the honorary lecture position at Institute of Clinical Science, University of Birmingham, UK, for his contribution to clinical research and a lot of books, publications. I would just highlight a few regulations governing clinical trial in the book. Fundamentals of Clinical Trial and Research is the much read one. He has been awarded the UK Seth Oration Awards for Best Clinical Pharmacology Paper by the Indian Pharmacology Society in 2009. And with this, the CV is not going to end, but I'm just going to mention an important point that he has been invited as a subject expert in pharmacology in the WHO-sponsored MBBS MD-DM curriculum national review meeting. That's an important aspect wherein we want to build this curriculum for the patient safety. He worked at Stanford University School of Medicine, USA as a senior clinical research associate. And we all know with this lot of rich expertise, he is going to definitely lead this panel discussion a great way and open a lot of arenas for clinical discussion, not only here, but way forward. And we will be having a lot of interactive sessions with the esteemed faculty. So Dr. Bhomik, request to introduce you all the other panelists on board today. With all this, I hand over to you, Dr. Bhomik.
Thank you, Dr. Ashwini. I think that was a wonderful introduction. Thank you very much. And I have with me a galaxy of stars from different parts of the country. And it's my great pleasure, as well as my honor, to discuss and initiate the panel discussion with Indian experts after our American counterparts discussed that some patient safety is not a problem of developing nations or the third world nations. It is prevalent everywhere. So without much ado, we are going to discuss implementation of the patient safety program. And our first panelist requires no introduction. Dr. Avinash Supe, Professor Supe, is the Emeritus Professor of Surgical Gastroenterology and Medical Education at St. GS Medical College, Mumbai. He has been the ex-director and Dean Medical Education and Major Hospitals at MCGM Mumbai. He's the past secretary of Asia Pacific Hepatobiliary Association, past president of Indian Association of Surgical Gastroenterology, and he's been a leader in gastroenterology in the country. He's the ex-chairman of the expert group of the erstwhile Medical Council of India. He is the chairman expert group of National Medical Commission. He's the chairman of the GI Surgery Board, National Board of Examination in New Delhi. And Sir is he has won the prestigious BC Roy Award, ANBI, MMC, MUS National Board Awards for a best teacher. So Sir is a clinician to core, but an excellent academician as well. In total, 51 awards to his kitty at state, national, and international level. The Professor Supe, we welcome you. He is.
Thank you. Thank you so much.
We are very honored to have you on board, sir. And my next panelist is Dr. Mr. Rajiv Chori, and Mr. Rajiv Chori requires no introduction as well. He is from a very, very important domain. He is from the operations and quality domain, and he is the VP of Quality and Operations at the Care Group of Hospitals, which is one of the leading chains in India. He is an MBA in Finance and a postgraduate diploma in Hospitals and Healthcare Management. He's done a postgraduate diploma in medical legal systems, and he's one of the pioneers of NABH in this country since 2006. He's a lead auditor for ISO 9001, 2015, ISO 14001, 2015. He's a fellow of Health Technology Assessment, certified professional in healthcare quality, and has over 28 years of experience in hospital industry, and is visiting faculty to multiple hospital management programs. Ms. Chori, I welcome you. It's a great pleasure to have you on board. Thank you for accepting our invitation.
Thank you for the introduction. Thank you.
And my final panelist, she is from Kerala, Mrs. Bobby Ramesh, one of a very dynamic nursing quality as well as quality leader. She was a former group director of nursing Indian operations at Parkway Pantai. She was a former director of nursing at Apollo Hospitals, Hyderabad region, as well as Jaslok Hospitals in Mumbai. She has over 25 years of experience in clinical teaching, administration, in nursing, and has been working as a quality head for 4 years. She is a principal assessor for NABH and is faculty at multiple training institutes as well as NABH training programs. Madam Ramesh, welcome to this program. Thank you.
Thank you, Dr. Subro. I wanted to add on to that. Presently, I'm working as a chief nursing and quality officer at Maitra Hospital, Calicut.
Absolutely. So she is the leader, the healthcare quality leader at Netra Hospital at Calicut. So without wasting much time, let me bring in Dr. Supe here. Professor Supe, you've been a teacher all your life and you've trained so many clinicians. Is it easy to involve clinicians in patient safety programs? Professor Supe.
Sure. Thank you, Vivek, for that interesting question. I think if you all realize that, yes, that's one of the most difficult part to bring the doctors on board for safety culture. And I think it begins with lack of safety culture in our systems, mature safety culture, I would say. Now, most of the doctors assume that they practice safety in a daily routine. They believe that strongly that all these kind of culture programs, they are not really that much put in a lot of effort into this. They feel it is for the other staff. And it's attitude, that many of them know, I know how to take care of my patient, nothing will go wrong. And this is not my domain. I will look after the clinical outcomes. Rest is all the management risk, That is what it begins with. The second is many times there's overwork and less staff. So they feel I don't have time and they don't prioritize these activities in the beginning. There's a lack of mentoring, that's what I feel, because whenever the new entrants come, like JMSs and junior consultants, they are not being taught this safety culture to begin with. And ultimately quality and safety culture has to be really mentored from beginning into the students. And as I said, these concepts have come recently. And unless they know about it, that there is a huge amount of errors to happen, whether they are prescription errors, whether they are, simple thing like say cautery burns. and cautery kind of surgical errors, falls, all these kinds of things, unless they are brought to them and you develop protocols and safety, and if you see last 2 or 3 weeks only, we have been talking about all this. I mean, the checklist phenomena book of Dr. Atul Gawande, which really brought this in much more. And the kind of errors, medication errors, which we continue, and all kind of surgical errors. And that is the reason I feel the doctors find it very difficult. So the main challenge is the attitude where they need to understand the safety culture. And then they try to, once they realize, it usually begins with some kind of an incident when the patient really suffers. And then they realize the value of this. So many of them learn by experience rather than prevention. So I think that's where we lack in inculcating this in our education. So we, over a period of time, it is coming, but it is still taking time for everyone to really absorb it as a culture in their own system. So that's the problem we begin with.
Excellent, sir. Sir, you are with the NMC as well, and I must congratulate NMC that NMC has brought in the concept of patient safety and quality for the MBBS students. What are your thoughts of having this as a specialty? Do you think India is not prepared or is still a long way to go to have?
There is no need for specialty. It has to be a culture imbibed at all levels of education.
All levels of education.
See, patient safety is a science-based practice and continuous improvement in reduced clinical errors. This is what we really need to do. And see, doctors mainly are a scientific community. They believe in facts and journal publications and also the smart evidence. So what we should really do, if they will buy it, only when we them understand, make it evidence-based, and then try to see that it has to come from top down. Ultimately, all these approaches are accepted by top down. Some amount of top down approach, some of it make it evidence-based, and then make them participate into every aspects of this. I think whatever is the medical aid organization, there has to be a continuous quality monitoring. And another thing which I always realize that if you find critical incidents, I think that is a point to learn. I mean, ideally, that's not the way, but in our country, many times what happens, there is an incident, make it a learning point and see that you establish a new practice effectively. And I think what I suggested also in our national curriculum also in postgraduate, that safety and quality should be a matter of, should be part and parcel of every specialty. In fact, now we are trying to revise all the PG curriculums, and we are making it saying that quality and safety should be, especially the clinical governance and quality and safety should be part of each curriculum. Every person, because see, today there's a lot of patients are asking artificial intelligence in coming in big way. Demands of patients have gone drastically different. So the new generation has to be ready with all these kinds of mandatory participation into safety training and initiatives, and also involve clinicians into hospital PSP and our safety initiatives. And I think also I feel we need to emphasize on mortality, morbidity audits, clinical audits, and strong clinical leadership, and hospital management will facilitate this, implement this program. So it has to be a pushed. I'm very happy that WHO brought this, something like that. I remember we had about 10 years ago, we had one speaker who really talked about the injuries which can cause because of the technology. All of us run after technology, but technology itself can cause a lot of injuries. So we should be very, MRI, the person can getting caught into MRI, causing deaths, like burns, and that I think everybody should understand that everything which comes new has its own other side. So we have to be very, ensure safety in all this. So I think we have to bring this culture into education and minds of every clinician.
I'm sure it will be there, sir, because you being there at the leadership position in NMC, things have started to change. I can tell you that because many of the MBBS students were talking to me and they were saying that, yes, we can pick up a subject in patient safety and quality and do research in the second and third year. So I'll move to my second panelist, my friend, Mr. Rajiv Shori. You've been wearing the hat of the quality head of such a big group. And I would say that Professor Supe mentioned a very important thing, that the approach should be from top down. How important is that the leadership should be involved in patient safety programs? And what is your experience? What are the major challenges when we have to really involve leaders into patient safety programs?
Yeah, thank you, Dr. Bhaumik, and respected Gyani sir. He is there on the panel. He has been my guru, so I take your blessings before I talk on this topic, sir. This is a very important area. Leadership makes a huge difference. And when we talk about leadership, it means influencing people. If one leader is not able to influence, he is no leader at all. So when a leader walks the talk of patient safety in any organization, now by leader, I don't mean only the CEO or the head of the institution. It's the HODs of various departments, it's the nursing in charges or the in charges of various areas. All of them are leaders in their own way. So they have to play an important role by walking the talk. So for example, if they say that we should not harm any patient in our hospital, but while they are walking and then they find water on the staircase and they just ignore and walk away, or they don't report it to anybody to get this cleaned, it conveys a different message altogether. Similarly, we talk about reporting incidents. So when somebody reports an incident and if a leader ignores it or thrashes him saying that no, you are not supposed to talk all this in this meeting, the culture will never be formed and patient safety will never be the focus of that organization. Even though there will be a lot of posters around, there may be a lot of events organized, but if this kind of message is given by the leaders, patient safety culture can never be incorporated. The challenges that we face is most important is their availability of such leaders during these important quality meetings or patient safety events, or you look at important incident reporting, root cause analysis. Suppose it is being conducted in any organization, the main person is missing from the root cause analysis meeting, and then it becomes just an eyewash because he's not there. People talk and then they come out with certain suggestions, but there is no one to approve those suggestions. So it is said, okay, we will forward it to the top person. Once he or she approves, we will look into it. And that approval never happens because he has no time. Now, not that they are to be blamed, but they should take out some time to ensure that they are available for patient safety discussions, patient safety events, and it will make a huge difference there. Second important thing we need to have is there is a lot of pressure from boards nowadays to generate revenue, generate EBITDA, generate profits. Now in that process, the focus on patient safety discussion in board takes a back seat. Senior leadership has to ensure that the board meetings always have patient safety as one of the agendas. It should never be missed. If that is not there, it is a major challenge because board will always focus on how much have you generated, how much have you saved, but would not talk about how much you need to spend on improving patient safety. So the challenge is that the senior managers should be courageous enough to take it up to the board and then bring it to their notice that these are the areas where we need to work on patient safety. The third challenge which we face from senior managers is promoting no blame culture. They should take it up as their one of the most important responsibility and accountability to drive this no blame culture across the organization, whatever it may be. So these are the areas where I feel we have challenges in from the senior management point of view.
I think you just said my mind. You just said whatever happens in probably every other hospital, and not that our leaders are not available. Sometimes they're just too busy. I will go to Dr. Girdhar Gyani sir once. Sir, are you there?
I think he has left.
I think he's just disconnected.
Okay. No problem. No problem. Maybe I'll come back to Supe sir on this because he's the leader right now as an executive director of Hinduja Hospital. Before that, I'll finish with Bobby Ramesh. And Madam Ramesh, you are a quality head now, but you spent a lot of time motivating nurses. You've been a nursing leader for 25 odd years. What are the major challenges? I know nursing they really take up the beacon of quality in hospitals, but what are the major challenges when it comes to motivating nurses for involving them in patient safety programs? Bobby, you are muted. You're muted. You need to unmute.
Thank you, Dr.
Yes.
Baumi. First of all, I'd like to thank the organizers, and I'm extremely privileged to be part of this esteemed panel. And as you rightly said, it's not because I'm a nurse leader, but you also know, and Rajiv sir also knows, that in a hospital, maximum contribution to quality, be it in sitting for training or initiating an incident report, it is maximum from the Department of Nursing. Having said that, there are definitely challenges too, especially in the present day scenario to implementation of patient safety program. The most important challenge is the attrition and turnover of nurses, because of which training will be affected. We'll be, training the nurses on patient safety programs. Because of frequent turnover, the nurses keep moving, and the new ones come again. We have to start afresh, which compromises on some of the processes related to patient safety. The second one, because of nurses leaving for abroad and this attrition, there is acute shortage of nurses across the country, not only in our country, globally. So these shortage of nurses leads to, the improper staff-patient ratio and workload of patients on the staff. The more staff gets, overloaded with more number of patients, it leads to more number of errors, including hospital-acquired, infections or pressure ulcers, etc. So this is the second most important thing. And thirdly, I feel, the communication skills of the nurses. I definitely feel across the country, I visited many hospitals I worked in. The communication skills needs improvement. Though some are very good, but most of them need to develop their confidence levels and improve their communication skills. Sometimes they are scared to, talk to a consultant even, and they are scared to ask for any clarification if a verbal order is given, and because of which errors do happen. The fourth would be, I will say, lack of support and lack of empowerment, especially in our country. Having been trained from the Armed Forces Medical College, we were treated at par with the doctors. We were empowered to take care of the patients 24/7, be it in the ICU or in the wards. It was the nurses who used to be taking care of the patient. Outside, the scenario is not like that. There is so much of disparity. And because of the lack of empowerment, many a times errors do happen, because in a hospital, if the verbal order policy says that no medications can be ordered verbally, and if the doctor orders, in Western countries, definitely a nurse would question a doctor and she will say that I cannot give this medicine. But here, nurses are scared to check a doctor or anybody else, and then they carry out the orders blindly. And in the process, also errors do happen, and finally they would be blamed. If though they want to do at times, the hospital or the leadership may not be supporting them. So the lack of support would be there. And lastly, I'd like to say one of the major challenges is that competency of nurses is a very, very important issue. Gone are the days when every college or a school of nursing had a parent hospital where the nurses had hands-on training when they were students. But now many places, there are a lot of malpractices, and they do not have parent hospitals, and they never had seen hospitals, and they finish their nursing degree. And when they come to the hospital, it's very, very difficult to train them in the initial period. And there is no training, that gap of training period given, and straight away they are given patients, and because of which there will be a lot of patient safety related concerns. So these are the things, by the time we teach and train them and the competency is improved, it will take at least 3 to 6 months. So definitely during that time, there is a challenge in implementing, a patient safety program in a hospital. So these are the major challenges with regard to nursing when it comes to implementing patient safety program.
Right, Bobby, I think you are very pragmatic, and I really respect you for that. And communication gap, that's one of the major issues, not only within the nursing and the doctors' fraternity, within the doctors' fraternity. I think doctors sometimes don't talk to each other. And I'll just tell you that the recent report which has come out for the unfortunate Air India crash, which happened last year, one of the reasons for the crash was inappropriate communication between the first officer and the chief pilot. So that resulted in that 1 in a million crash, and that happened for the unfortunate people who were flying down from Dubai. So I'll come back to Supe sir here. Sir, both Rajiv as well as Bobby are mentioning that leadership support is extremely important and no blame culture has to be maintained. You are a leader, sir. You are a leader. You've been an academic leader. Now you are at Hinduja as an executive director. How do you promote this culture in your organization?
Fine, sure. I think very nicely said by Bobby and Rajiv. I think the way they really brought out from top down, the culture is very important. Now, how do you develop a culture? I will go back a little differently. I will just say it depends upon what is your superior management keeps as parameters, of kind of evaluation. That matters a lot. To give you an example, when I was a junior resident, we used to fight, I did hernia in 20 minutes. Somebody said I've done in 25 minutes. That kind of a fight we used to have. That time, one of my professors very nicely told me, he said, you must realize that time is not something, but the quality, the infection, the complications, that matter a lot. And he gave me a very nice example. He says, look at a city bus service. If in a city bus service, you keep a parameter as everything has to be on time, then then accidents will increase, because then the driver will really try to rush and they'll be. But if you say safety is no accident is our policy, then automatically the way the bus service is run will be different. Now, the same thing in a hospital we have to really see. We have to emphasize that safety and quality is our parameter. Of course, every hospital looks at the profit, but I think there is more important to the patient safety and quality, because that matters for your long-term reputation. And you have to emphasize, and the culture you develop is you don't have to be very punitive. See, most of the doctors run away from the culture and safety culture is because they feel there'll be punitive action. But what we have to do is we have to really concentrate on curative, corrective, and preventive action. So the whole thing has to be managed in such a way that you are not allowed everybody to do whatever they want to do. You don't have to be extremely punitive, but you have to make them realize that somebody is watching, somebody is looking at it very carefully, somebody is looking for the corrective and the preventive action, and we are looking towards improving day by day. I think if you keep that approach, then slowly you will find over years people understand this and people start improving. So when you're trying to develop a culture, it takes time. It doesn't happen easily. When you start beginning, people oppose because they are worried about the punitive action. They're worried about getting exposed themselves. But over a period of time, when the superior management starts looking at it from a different approach, I think that's the time the quality culture starts seeping into the organization. Most of the institutions, like very excellent lecture by Julia and David, where they say even Howard and this, when I was also fellow in many American universities and graduates, there I've also seen, there were also complications. There were also many kinds of safety issues were compromised, but that was not the way they handled. They handled it by corrective actions and trying to prevent them rather than trying to repeat the same mistake again and again. So I think that's the way you would like to really imbibe that culture in organization. It takes time, but the superior management's approach makes a lot of difference.
So we should be patient, and patience can only give us patience.
Not patience, the direction has to be right.
The direction has to be right.
Persistence and continuously looking at it and putting it on everybody's mind every month. There has to be safety committee meetings, make people realize, make people present.
But milestones are also important. Like if we say that we have to have these meetings every month, so we need to have those meetings.
And make a participatory stakeholding, make all stakeholders participate. Then they own it. Then they own it, rather than you trying to push it down.
Absolutely. Make all stakeholders participatory. That is a very important thing which Supe sir is saying. Rajiv, I'll come to you. You said a very important thing, to have patient safety is one of the important outcomes in board meetings. How do you motivate these boards? Why would they put patient safety as one of the outcomes when we are only talking about profit and loss? How do we impress the boards on that?
And Dr. Subro sir, very, very, very difficult question. because patient safety is definitely the priority for everybody on paper, yes. But when it comes to spending money, everyone starts thinking, will it give the desired results or not? Now, as Avinash mentioned, a very good example he gave of the bus. If we tell the board that if you want to make money, it cannot be done in a short term. If you should have a long-term perspective in your mind, and the best way is to improve patient safety. And what we do is in our board meetings, we ensure that we present our infection control data. So when we tell them that by doing this measures where we spent, let's say, a few thousands of rupees and brought down the patient fall or infections in the hospital, by doing this, we have saved much more money than we would have saved avoiding it. So that makes a huge difference. And with that, board gets interested in trying to see different metrics. Now, when you present a matrix to board, please, we need not present everything to them. Just a small dashboard where 5 or 6 important parameters related to patient safety are presented. And the reasons for not meeting those targets or reasons for meeting those targets should also be presented to them. Then they get really very much interested, and then they focus on patient safety aspect also. Second thing we need to do is when we do the training programs for other staff members, we must request board members to be the chief guest or chairperson or one of the faculties. So when they take part in these kind of activities as faculty member or as chief guest, they definitely start following up what's happening on that initiative. Where are we on that patient safety aspect? How much money have we really spent on improving patient safety facilities in our hospital? So their involvement in such programs will make a huge difference in ensuring that they get involved into these activities.
Great. Those are great tips, Rajiv, and we are going to carry those back definitely. And all our people who are, because we are asked once in a while to appear in front of the board and we need to impress them. Absolutely the similar way. Bobby, I will come to you, and you are a quality head of the hospital. Sometimes we don't meet the desired outcome. Then, the leadership is not very happy. And sometimes the question comes in whether, everything is related to an outcome. And if I could say very unfortunately in India, it is related to accreditation. That, everything is hovering around accreditation. If you have a good accreditation outcome, you're accredited, that means you have a good patient safety program. You being an NABH principal assessor, do you agree that accreditation is always a yardstick to measure the patient safety program, or there are other aspects as well? Bobby, you're muted again. Please unmute yourself. We need to hear you.
Yeah, so accreditation is not the final destination. So if a hospital, though there are hospitals which feel if you are accredited, they will flaunt that as, their hospital promotes patient safety, whereas in real, they may not, just for the sake of getting accreditation for various schemes and attracting, various category of patients, they may do it. And even a quality department will be temporary just for the accreditation. That's it. But whereas there are some hospitals which have really, really improved from the scratch by streamlining each and every protocol, each and every department, starting from the fire safety, to medication safety, to infection control and in prevention, and they have really improved in all their patient outcomes, and they have promoted patient safety, and they have come out very successfully for the accreditation. And such hospitals where there is a drive from the top, I always reiterate everywhere, even here wherever I work, the leaders must drive the patient safety program. It is not from the juniors to the leadership or juniors to the HOD. It is always driven from the top. If the leaders drive the patient safety program, we can always sustain the program, and we can take the hospital to greater heights in terms of promoting patient safety, also by improving the patient experience as a whole and improving patient satisfaction.
Yeah, absolutely. Well said. And I completely agree with you, Bobby, that sometimes, accreditation are not the only yardstick, because it is beyond that. the commitment to do it every day and not on that those 3 or 4 days when the entire decked up approach comes in. So we are nearing the end, and we had a fantastic discussion with our 3 exceptionally talented as well as experienced panelists. I will go one by one now, and last tips I would take from each of you. What do you think is the most important component to have the successful patient safety program in a hospital? And this is going to be one tip only. So we'll start with Supe sir. Supe sir, what is the most important component to have a successful patient safety program in one hospital?
Let me see, we have to bring this culture. So document it, make it evidence-based, and participate everyone. I think slowly you will be able to bring that culture of patient safety culture and quality program in your institution. It's a slow process, but it's a persistence, and with your passion, you will be able to do it.
Thank you, sir. We will now move to Rajiv. Rajiv, one most important component to have successful patient safety program in a hospital.
Yeah, promoting open communication and allowing people to speak out is the one most important factor that I feel will go a long way in ensuring patient safety culture.
Thank you, Rajiv. Thank you. Promoting open communication. Finally, Bobby Ramesh.
I'll tell 2 points because I'm taking care of nursing, nursing and quality in my hospital.
Yeah.
Definitely, I feel the nurses have to be well supported and empowered, and there should be a open door policy, and there should not be any steep hierarchy. This is, from the nursing point of view, that will go a long way in improving patient safety. And from quality point of view, I will say that an accreditation or a patient safety program is not driven by quality. Many people misunderstand, including the management, that accreditation is the responsibility, or a patient safety program is the responsibility of quality. No, it is a responsibility of each and every department and each and every department leaders. So it has to be decentralized. Quality should not be centralized, it should be decentralized, and all the leaders must drive together so that the patient safety program will be successful.
And I will add one from myself, is that, a very important stakeholder is the pharmacist. We tend to forget their role, but they're extremely important. So as Bobby mentioned that, the nurses need to be well supported, I would add the pharmacists in India, especially the hospital pharmacists, they're not vending machines. They need to be well supported as well, because as we heard Professor Bates, that's the
very true. Very true. I think you said it. We must respect clinical pharmacists and the pharmacists who come, because they are also the part of medication
management. So before I close, I just want to sum up the excellent discussion which just happened. I would say that the panelists agreed that patient safety programs have challenges in this country, but we have come a long way. It is a slow but evidence-based approach which is going to help us in the right direction. The leadership must be involved from the very first day. Leadership must encourage open communication. Nurses need to be well supported. There should be an open door policy, open communication with different stakeholders. And finally, I would say that quality is everybody's business and patient safety is everybody's duty as well. So let us, with these thoughts, close this discussion. And thank you to the organizers for organizing this wonderful panel discussion. Over to Dr. Ashwini for the closing remarks.
Thank you, Bhaumik, for very nicely conducting. We really appreciate your.
Thank you, Subhesar. Thank you.
Thank you, Dr. Bhaumik, and thank you all for giving us this opportunity.
Thank you, Dr. Bhaumik, and all the esteemed panelists and the organizers, and Dr. Ashwini as well. Namaste, everyone.
Thank you. Dr. Bhaumik, I would like to take this opportunity to give you a few more views. I know you have a lot of work in patient safety. In between, we discussed we could have some workshops or safety program for the pharmacists, which we all forget. So I would now like to take the opportunity, 5 minutes, if you want to address us, your views now. I know it's impromptu, but I'm sure your You are enriched with experiences. I would like to hear from you also.
Dr. Ashwini, I think my views were echoed absolutely well by the three panelists. I will just say that it is not today that we should remember patient safety as everybody's duty. And I think Supe sir mentioned a very important thing, evidence-based.
Yes.
Gone are those days where, you know, I used to believe or my boss used to believe or he used to do this way. So I think it should be the clinical decision support system and evidence-based approach is the way ahead. And it is all, I won't say way ahead, it is already here. Whenever I think the biggest problem in patient safety is litigations, and none of the hospitals which are sitting here want to be in the bad books through litigation. So we have to do our every bit to prevent this as well as prevent the harm to the patient. So I would say that evidence-based medicine practice, whether it is in terms of patient management, whether it is nursing care, whether it is medication safety through clinical pharmacists, we have to do it. Even fire safety, it has to be evidence-based. This is something I believe that the good hospitals in India have embraced. I would say the good, not so good, yet trying to be good hospitals are in the transition. So we need to embrace that in totality. And lastly, I would say that every one of us should believe that, you know, we should not do any harm to our patients, even if we are not able to improve the patient's condition. This is very important, as Hippocrates mentioned in his ode, that primum non nocere. This should be the ultimate mantra of patient safety on every day, not today only. So with this, I would say that, yes, we are on the path. NABH has helped us. I want to acknowledge the role of NABH which has started by Girdhar Gyani sir and Quality Council of India. That today we have been, there are so many participants who are attending this, and every one of them, some of them I know, Antonio ma'am, who's one of the leaders in patient safety, she has implemented different unique initiatives in the state of Karnataka. So we have done our own bit, but the journey has to still go on. And initiatives like this, we have to keep on doing. And lastly, I would always request, mention that, you know, we have to publish our own data. As Professor Bates showed in his presentation that the data was from Harvard and that gave him more confidence. I think it is extremely important that we, as Indians, we should publish our data and contribute more to the evidence-based literature. Thank you.
I agree. A lot of valuable inputs from all the esteemed panelists. It was indeed an honor for all of us to get your views here on World Patient Safety Day. With this, I come to the formal vote of thanks. We would like to thank all panelists in the busy schedule. They removed the time. We had a lot of good interactive discussions. Lot of takeaway home messages was there, not only for us, for the top management also. And it should be a day-to-day activity. And this is the way we support our WHO initiative. With this, I would like to thank again formally Dr. David Bates, who was the chief guest for today. Dr. Girdhar Gyani sir, who has been always with us in all our programs, mentoring us. Dr. Julia Johnson, Dr. Subrajita Bombing again. Supe sir, we have interacted. Sir has been my mentor. Thank you, Supe sir. Thanks for valuable inputs. Now he is on the role of he's a director of clinical governance there. So a lot of inputs for clinical governance, the top management, and how the faculty should enlighten the students. Thank you, sir. Dr. Rajiv Chori, sir, you also gave a lot of valuable inputs in the boardroom, how it should be, and we should focus on patient safety. Bobby Rameshji, I really thank the practical things what you touched. We all face, and now we feel, yeah, we are all in the same boat, but yes, together we will fight. Problems are going to come, but definitely we need to tackle this. We need to go way forward. And in this era of consumer era, wherein patients are very well read, social media is there, they are reading everywhere. We need to again educate them, empower our people, and we all need to be on same like management, clinicians, the staff. We need to work hand in hand for this patient safety. Let not be it a single day event or a single hour event, but it should be a day-to-day event. We would love to have such interactive sessions again. And I would really thank from bottom of the heart the organizers who took It was not easy to get this galaxy of, it's a galaxy of all the eminent personalities what we have. We are from Harvard, we are from St. Tompkins. So that again helps us to give confidence that no, we are at par, or maybe we can do much better when we see all the publications and all the data. So thank you, Voltus Clover and Up to Date. And really, I would like Sagar on a personal note, who took it on a very fast level. Voice of Healthcare India, thank you for organizing this wonderful conference, supported by very own AHPI. We ourselves represent AHPI. Without your all support and the august audience who have been with us patiently, they have been before time, they have chatted, a lot of questions have been asked. And thanks the audience for participating and having a wonderful session. With this small thank you note, I would like to have a formal closing ceremony, wherein with this note that we should all vouch, we should all pledge that we will work together for World Patient Safety Day. Again, we reiterate that on 17th September 2021, today, we support WHO's initiative, which urges all stakeholders to act now for safe and respectful childbirth with the theme Safe Maternal and Newborn Care. Yes, it's a very important element. Safe mother and safe neonate and safe child are the future assets, and they're intangible assets of a healthy nation, of a healthy world. With this small note, we would like to end this small session. Thank you all. Namaste.
Namaste, and thank you, Dr. Ashwini, for your